A person living with diabetes in a poor and remote village is less likely to be diagnosed, less likely to receive timely treatment, and more likely to have complications. This social gradient cuts across all health conditions, whether it's malaria, diabetes, or breast cancer. But it's hidden from the health systems meant to address it. Only 3% of low-income countries are able to monitor health inequities by socioeconomic position without external support. Nowadays, in order to get health equity data, we need to send teams to collect data from households, ask them about income, about their health conditions. But recently, in 2025, the global health funding crisis disrupted these household surveys, which informed us on equity monitoring in dozens of low and middle income countries. At this moment, AI proliferates in health without the systems to assess whether disparities are narrowing or widening with our new innovations. Geospatial artificial intelligence, or in short, GeoAI, could provide a solution or a new approach. It's integration of geospatial data with machine learning. To put it simply, think about it that you have several layers of maps that inform you and allow you to answer specific questions, such as how is poverty distributed across an area, across a country, or even across a continent. For example, night lights can show us high-income areas as glittering, shimmering lights emitted from villages or high-income neighborhoods, whereas dark areas are associated with poverty. This information can be seen from space, and also high-resolution satellite imagery can inform us about the material a roof is made of, so we can better understand the social context of where people live. These models were already validated across low and medium income countries. And in sub-Saharan Africa, they've shown accuracy rates reaching 85 to 94% in estimating socioeconomic position when compared to household surveys. However, these new models are not integrated with routine health information systems. This is a typical routine health information system. It would usually include a person's address and some clinical information, such as on screening or on treatment. But what it does not include is a socioeconomic position. Using GeoAI, we can now enrich health records with this missing link in our health records. And then we can aggregate this into health equity-informed dashboards to give decision makers the tools, show them the gaps in treatment and screening across health conditions wherever it's recorded. And then we can also reach the people who need the care most. Sir Michael Marmot has coined the term leveling up care, which is improving care for all while directing efforts proportionately to need. This system is being built with 4 principles aligned with WHO ethics and governance framework for AI in health. First, geoprivacy, so that location data never exposes the individual. Second, explainability, so communities can see what drove each estimate. Data sovereignty, so national health systems remain in control. And most importantly, equitable access, so the tool works offline and at low cost, precisely where it's needed the most. So I invite you to reach out as I'm building this tool at the University of Geneva. You can scan the QR code and email me as well. And I am very much looking forward to hear about your work and where you see a connection. So thank you very much.